Chapter 7, Trail Guide, 6th edition, is the bones and muscles of the leg and the foot. We're going to start with diving right into the bones, and then we'll finish with the other structures, go to the muscles, and then do the actions all the way at the end. Starting on page 346, I want you to notice that I'm not going to focus on this visual right here. I'm going to look at page 354 for that. Instead, I want us just to focus in on what I have identified here in the highlights. So first of all, we need to verify that the tibiofemoral joint is the knee joint, the largest synovial joint in the body, and a modified hinge joint. That's going to be important for you to remember for going on to take the state exam. There's those little things that we want to make sure that you have highlighted. This joint is capable of flexion and extension, and when we have our knee flexed, which is bent, that it can medially and laterally rotate. So if you're sitting, you can move your knee to the outside laterally or to the inside with your knee bent. So the proper term being the tibiofemoral joint. So it is where the femur and the fibula and tibia come together. And those are going to be our two long bones of this chapter. The tibia is what we'll call the shin bone, most superficial. So if you just reach down, touch below your knee, you're going to feel that. But then the fibula is a thinner, lighter bone that only holds about 10% of your body. And notice that it is going to be on the lateral side, and the tibia is more medial or in the center. I'm going to scoot this picture down to have our first term for the ankle joint. So notice we have the proximal tibiofemoral joint, which is your knee, and then we have our distal tibiofibular joint, so where the tibia and the fibula end down, that creates our ankle joint, talocarpal joint. Always have your proper terms of your joints. We're going to still focus on the tibia and the fibula. Page 347, the left-hand picture. What I want you to notice is the things that I have highlighted, but also all of the terms that are on this page. So at the top, we have the lateral and the medial condyle. So if you're not familiar with what a condyle is, it is a bump. It's going to be a protrusion out of the bone, but that is a term that you need to know. So we just have what's on the medial and the lateral. So this is the top of the tibia bone, which is below the femur. I have the tibial tuberosity circled, so that is the bump that's right below your patella, and that is where the quads insert. Pes anserinus attachment site we talked about in chapter 6 if you've had that chapter, and it is going to be a site that is a little separate from that tibial tuberosity. If you just look at the difference between the tibia and the fibula bone, you can again see how one is a lot bigger, the other is a little smaller. That's why only about 10% of that weight is on that fibula bone. But we have still the head of the fibula at the top, and I have written there that bicep femoris, so that should jog what group of muscles is bicep femoris in. That's what I want you to think about. The shaft of the long bone is always the middle part. And then at the bottom, we have the lateral and medial malleolus. So these are just the knobs that actually are creating what we see visually on the distal end of those two bones, which is creating that talocarpal joint. So just those knobs, meaning the medial and lateral malleolus. Especially for this chapter, but for all chapters, always make sure that you look at the view that they have. So this is an anterior view, this is a posterior view on the right-hand side. Still pointing out some of the same things, the head of the fibula, the lateral condyle, We do have the soleal line here. That's going to be for our soleus muscle, and we'll talk about that here in a couple pages. But I also want to have a better view, which is what we have on the next page. Just for a little quick review, here's our patella, kind of that heart-shaped. It's the largest sesamoid bone in the body. So just what that patella looks like. So for a little bit more up close of what's going on at the knee, we have page 348. So I want to point out the same things that were on that previous page. We have our medial condyles and medial epicondyle. Epi means always upon or above. So this is the bump that's above. But notice where they're going. They're talking about the femur. And then we get to the tibia. So this is just creating our whole talocardial joint. So what happens with that patella bone, what the femur is doing, how it articulates with the tibia, that's what we're looking at here. So just where everything is, and this is a bent knee or a flexed knee here. The other picture on 348, again pointing out the lateral, epicondyle, and condyle. The top picture has the medial, so the inside and the outside, medial and lateral. But I also want you to notice the head of the fibula, and then again that tibial tuberosity bump. And again, still the flexed knee or the bent knee, and it's just showing different view, medial and lateral. So this is what our knee looks like, that articulation. And then this box on the bottom left-hand side is just reminding us that, again, in the flexed position, this tibiofemoral joint can medial and lateral rotate. So that largest synovial joint in the body, making that happen. The next page that I want to go to is still sticking with the tibia and the fibula and just focusing in on a few points. There's not very many. Page 350. So for the patella, you do need to know that that is the largest sesamoid bone in the body. Way back in chapter 1, we talked about those different terms for the type of bone, so being the sesamoid bone. And I have highlighted there that when we bend our knee or flex our knee, the patella seems to go away, but it's really just sinking into that space between the bone or between the proximal tibia and the femoral condyles, or the bumps on our femur. And you can see at the bottom how that is occurring. Your patella is movable. It's kind of a free-floating bone. On the right side of page 350, just sticking with that long shaft portion of the tibia, we have that the tibial tuberosity, which is where one group of the muscles of the upper leg attach or insert, so you should always remember that one, but that it is distal on the shaft of the tibia. So if you look at the bottom picture, again, the patella kind of points right to it, so just knowing where that tibial tuberosity is located. On page 351 at the top, just being able to identify where the head of the fibula is. So you can use that tibial tuberosity as a little bony landmark to go lateral and find the head of the fibula. Bicep femoris muscle attaches to it, as well as our soleus muscle, and we'll look at the soleus muscle here shortly. So as far as the tibia and the fibula, the last part that I want to talk about, I believe, is something that if you've had chapter 6, you've looked at this. This is our pes anserinus attachment site because it's on the tibia. So we want to identify the tibial tuberosity, which we just talked about, being right below that center point of the patella. And then the pes anserinus attachment site is medial to the tibial tuberosity. This is an important site because of the 3 muscles from the upper leg that attach to it, but it is on the lower leg. But between these sartorius, gracilis, and semitendinosus, that creates a lot of movement on our knee. So when people have limited range of motion, or potentially they have discomfort or pain when they bend or straighten their knee or flex and extend it, we really have to remember these three muscles and this pes anserinus attachment site. This is the insertion site, the most movable site for those three muscles. So that's why it is important that we keep that in mind. So that is the patella, the tibia, and the fibula. So now we're going to turn to page 354 and focus in on the bones of the foot. We do have to keep in mind that we have a total of 26 bones in our foot. So if somebody says, well, you know, I broke my foot, there's a lot going on there. And who knows what bone was dislocated or broken within the entire foot. And most of the time clients don't know either. So if we just look at, we're going to start at the heel, how the paragraph lays it out. We have the talus bone, which is where the tibia and the fibula come to form together that ankle joint or the talocranial joint. So this is our talus bone. You can see on the next page, I'm not going to change the view, but the next page also has another view of the talus, and we'll look at some of those in just a moment. Then we have our calcaneus down here. This is the heel. So this is the bone that forms the heel. Then we have 5 tarsals, and they have in the paragraph that they're small and uniquely shaped, and they're tightly wedged together. So, and they are more accessible on the top part or the dorsal surface of our foot. So that is our medial, middle, and lateral cuneiforms and the cuboid. But unfortunately, the last one, I'm sorry, I didn't highlight it. It's right here, sorry. Tarsal navicular. So that's the 5, 3, 4, and 5. So they're kind of in the center, more in the top part of your foot, more accessible there. Then we have our metatarsals. So this area right here, which is like the palm of our hand, it's like the forefoot, or we can call it the forefoot. So they have the shaft, the base, and the distal head. So we have each little part here. Again, on the next page, they show that a little bit better. Then we have our phalanges, which would be just like in our fingers, it's our toes. So the big toe or the great toe or the hallux only has 2 phalanges, but the other 4 have 3. So there is a difference. We'll focus in a little bit on those in just a moment. On the bottom of the page, we have the breakdown. Might be easier to see it up here, but it is easy to see how these tarsals are all coming together, those 5 bones. On the next page, 355, let's just look at that top picture. And again, I just have the areas highlighted to help us identify these bones. So the heel, calcaneus, the talus, which is articulating with the tibia and the fibula, the cuboid, navicular, lateral, middle cuneiforms. The medial cuneiform is on the bottom picture. Those are those 5 tarsals. We have the base, shaft, and head of the metatarsals, and then out to these phalanges. All right. So this is our lateral view. The bottom picture would be our medial view. So this is where we have that last tarsal, the medial cuneiform. They're just identifying the base of the first metatarsal, which would be our the forefoot of that big toe. And then I do like this side view, so more of the calcaneus. This is our heel, and then the talus, which is articulating with the tibia and the fibula. You do need to know all 26 bones. You do need to know who touches who. So we're going to focus in on that a little bit more on these next couple pages. Page 357, notice here, and you will be able to visualize these on yourself as well as any other person. So the bumps that make up our ankle area, they are the lateral and medial malleoli. So not an ankle bone, It's the lateral and medial malleoli. You need to know the proper terms, especially if you need to document something that occurred within those areas, or there's maybe swelling or edema. The calcaneus bone on page 358, it's just giving you an up-close view of the heel bone, but you can see it definitely has a lot of grooves, a lot of information going on there. You don't have to focus in on each site. The workbook does take you through that, but I'm not going to ask you those questions on the chapter test, but you do need to know that the calcaneus is the heel bone. The next page that we're just going to briefly pass through is page 360. So the talus bone, this is the one that is articulating with the tibia and the fibula. So you can just see that unique shape of it. Then we're going to skip to the bottom of page 361 to look at the great toe, or the big toe, which is known as the hallux. Again, it has just 2 phalanges, where the other ones have 3, but it is a large ellipsoid joint. And then right here where this thumb is in the picture, that's that bullous shape that sometimes we might see on people as a bunion, but it's just more prominence of what is happening here. So you do need to know the proper term for that big toe or great toe. The same goes for page 362 at the top. Just like in our hand, our little toe also has some specifics to it, just like our thumb and our pinky in our hand. Same goes on in our foot. So first of all, we want to know that it is, I'm sorry, we're still talking about the big toe. I apologize. We're not going there yet. I'm jumping ahead because I was looking down here at the bottom. So we're still talking about that big toe. Let's go backwards a little bit. And what I want you to look at in this picture, so notice the hallux, and then see the redness that they have here. That is the muscles that are underneath our great toe or our hallux. And here I have circled, just pointing it out a little bit more. This is what can be the area that is irritated when we have a shoe that does not fit properly. Keep in mind that we also have shoes that have arches in the bottom of them or on the side. So this first metatarsal, or that great toe, can create more of that bunion from what is happening on that plantar surface, which is the bottom surface of our foot. So keeping in mind, especially when clients have particular aches and pains in their ankle or their knee or their pelvis or their low back or their shoulders, this has a lot to do with it. So knowing what's going on with their shoes is going to be important. Focusing on the other 4 toes, or the 2nd through the 5th digit, where again those 3 phalanges. So we have our hallux that has 2, that large ellipsoid joint, and then we have numbers, toes 2 through 5, which just have 3 phalange joints in there. Same thought process, 2nd through 5th metatarsals, so this is the longer part of our foot through here. But this is where I started to get excited just a few minutes ago, because I want you to notice this bump on the pinky toe side, and notice how that little hook is there, a superficial knob. You can also see it on the bottom of page 363, so just showing this superficial knob. If you have a shoe on right now, I encourage you to take it off and try to see if you can feel that. You can identify the pinky toe, go down the side to find this, and it's more towards your toes than your heel. But this tuberosity of the 5th metatarsal, the superficial knob, not only do you need to know where it's located, but it's going to be important because of the muscles that attach to it, which are on the lateral aspect of our lower leg. So this is also a common site that people will complain that, yeah, my foot really hurts. and you can pin your finger right on that spot and know that it is the tuberosity of that fifth metatarsal. Okay, focusing in on some of those tarsal bones, we have on page 364 the medial, middle, and lateral cuneiform. So these are going to be important because of the muscles that attach to them. We're going to have one muscle from the front of our lower leg and another muscle from the back of our lower leg that are going to go in between these. So medial, middle, and lateral cuneiforms, they tell you where they're located. You just need to know where they're at on the foot, and then you should be able to keep them in line based on their names. Navicular is the one of the other tarsal bones. So you can see in the picture, you can find this bone, and it is a little bit more bulgy on the inside of the medial foot. So that gives you an idea of where you can locate it. Again, one of the muscles from the back of our lower leg is going to attach to it. I do also like this middle picture on 365 because you can see how you can identify the tuberosity of the fifth metatarsal on that pinky toe side, and then navicular. So this might help you. And then cuboid is the other tarsal, so they're just showing you how to locate that. And the bottom of 365 is the lateral view, whereas the top view on page 365 is the medial view. So two opposites, but those are all 5 of those tarsal bones. So that's all of the 26 bones of the foot. We talked about the tibia and the fibula for the lower leg bones, a little bit about the patella. We don't have to focus too much in on that patella. But now we have to go to the back of the chapter so that we can look at the structures that are on top of the bones before we talk about the muscles. So page 392 is where we're going to go. On the top of page 392. Take a moment, look at all the things that I have highlighted. I want you to write in the things that I have here. So genu valgum, genu verum, I want you to write those in. You might remember those from an anatomy class. Otherwise, you do need to make sure that you know those 2 terms, and we will talk about them here in a couple pages. But this is going to help with that tibial collateral ligament and the fibular collateral ligament. Notice the other 2 ligaments at the top that I have highlighted. The posterior cruciate ligament and the anterior cruciate ligament. Cruciate means it kind of forms a cross or an X. And we have the anterior and the posterior, also known as the ACL and the PCL. So the ACL is a little bit more common. But what we have is the ligaments that are highlighted in orange. So I've written here that a ligament is a fibrous connective tissue connecting bone to bone. But it is relatively avascular. It has very little blood flow. It does have blood flow because it's alive, it's connective tissue. But this is how the oxygen and nutrients are coming into the ligaments at where it attaches. So that's why when we damage a ligament, it's going to be harder for it to heal or to recover in its process. So especially in the knee, we have a lot of connection going on. When we look at this tibio-collateral ligament, which is on our medial side, it's going from the tibia to the femur, and on the fibular collateral ligament, it's going from the fibula up to the femur. That's going to help with when our knee is flexed in that medial and lateral rotation. And then again, that genu valgum and genu verum, which is either bow-legged or knock-kneed. We're going to talk about those, but those ligaments are what are helping protect it. The other thing that I have highlighted here in pink is the medial and lateral meniscus. Notice where that is. It's kind of that cushion between the femur and the tibia. It It does not come down to the fibula. So just notice those things, and we're going to look at them separately. On the bottom picture, which is the posterior view of our talocardial joint, I'm pointing out again the lateral meniscus and the medial meniscus being that cushion between the femur and the tibia. I also have written on the bottom here, just so that we remember the difference between a ligament and a tendon. So the tendon does have a different type of blood supply because a tendon is connecting the muscle to the bone. So its blood supply is going to come through that muscle, but still the healing is slow. It's not like a blood vessel. It's completely different in how it gets that oxygen and nutrient supply, which is why we can also have problems with our tendons as well. So now we're going to look a little closer at each one of those things that I had highlighted. Page 394 at the top, we have the information about the fibular collateral ligaments and tibial collateral ligaments. So these are the ones that are connecting the femur to the fibula and the femur to the tibia. So the fibular collateral ligament is on the lateral aspect. The tibial collateral ligament is on the medial aspect. Both of these are there to resist medial rotation of the knee. So if your knee is bent and you're rotating it towards the other knee, that's your medial rotation. The fibular collateral ligament is also stabilizing the knee against genu varum, which is the bow-legged. So when we want to have our knees more in that lateral position, that lateral ligament is trying to keep stability in it. The tibial collateral also protects against genu valgum, which is knock-kneed. We could talk for a long time about what to do about each one of these pathologies, but you just need to know the terms and how they're affecting the knee. So the fibular collateral ligament is that genu varum, and the tibial collateral ligament is genu valgum. So the difference between the lateral and medial rotation, whether the knee is flexed or straight when somebody has been diagnosed with one of these pathologies, it's going to affect them when the knee is extended or flexed. Focusing in a little bit on the meniscus of the knee, page 395. So we looked at a better up-close view on the other pages, but here they're giving us one little magnified view. So we have medial and lateral meniscus. As the paragraph says, it's a fibrocartilaginous disc. It's there to help with weight distribution and friction where that femur and tibia are coming together. It is very thin, so it definitely can have damage that occurs to it. On page 396 is our next view, but I will tell you that we didn't see the bursa in that first picture that we looked at on this other structure part, but they are showing us in this picture where several of the deep bursa are located. But in the paragraph it says nearly a dozen bursa are there to help with this large synovial joint. So this is obviously not all of them, but just the primary ones. But we just need to remember what a bursa is. So that sac that's filled with that gelatinous fluid there to help with the friction, and especially in this large joint, there needs to be those dozen bursa to help us with all of our movements. The bottom of page 396 is just showing that popliteal artery, which is in the popliteal fossa, which is the space at the back of the knee. So yes, you might be able to feel the pulse there depending on what you're doing with your manual therapy, but also it gives us just where it's located. So just that blood flow, be aware of your pressure. The top of page 397 for the fibular nerve, and I have it circled here so that you can see. They don't have everything that I'd like in this picture, but if you read, it will help. So branching off of the sciatic nerve is the fibular nerve. So the sciatic nerve is coming out of that sciatic notch, which is from our sacrum through our pelvis all the way down the back of our leg to the back of our knee. And then this fibular nerve is coming down. Notice how it gets lateral. So that bottom part of the paragraph, it becomes accessible along the posterior surface of the head of the fibula. So when people have that pins and needles sensation down in their foot, we want to focus in on this area. Perhaps if their activities of daily living involve more of their knee being bent or laterally rotated, could be a reason why this nerve can be compressed or impinged. But because it does branch off the sciatic nerve, it can be a continuation of what is occurring up in our pelvis, which, as you know, can have a lot of other ramifications. Page 398, because now we're going to switch gears and go to the talocardial joint. So the top picture and the bottom picture, notice that I have circled just the deltoid ligament. We're going to talk about those in a moment. And then on that right-hand picture, I have the lateral collateral ligaments, and we're going to talk about those. So just so we have those areas circled so that you can look at the view of it after we get done focusing in. The top of page 401 for the deltoid ligaments. Deltoid means triangle. So these are the ligaments, and they're on the medial malleolus, or the medial aspect of our talocardial joint. And they're there to help protect against medial stress of this joint. So just look at how in-depth those are. There's a lot going on there, just bone-to-bone connection, really trying to stabilize this joint. And think of all the actions that we can do at this talocardial joint, right? We can roll it around, it moves our foot, there's a lot of things happening. On the bottom of page 401, they have the plantar spring ligament. That's going to be easier for us to think about. And again, just looking at all of this connective tissue that is for the bones. But what I have highlighted here is that it plays an important role in stabilizing the medial longitudinal arch of the foot in page 385. So yes, we need to do a little side note so that we can look at this, because this is where they're telling us about these ligaments. So we're going to backtrack slightly. Page 385, and here's where we're looking at. So I will describe this in class as the triangle on the bottom of your foot from the mound of your big toe to the mound of your little toe on the plantar surface and to the center of your heel. So we can look at this picture here and think, okay, that's where we're going. By definition, it's the lateral longitudinal and medial longitudinal arch, so the inner and outer arch, we can think of it that way. And then we have our transverse. So that's what's creating this triangle. Again, we'll work with that during class time. Very important for our posture that we're aware of this on yourself. This is something that you have to find on yourself. So now we're going to go back to page 401, that bottom picture. And here's the ligaments that are not only helping to hold the tibia and the fibula down into our foot, but also they're helping to support and stabilize that arch on the plantar surface of our foot. So how people have the position of their ankle has a direct correlation with what's going on the sole of their foot. We might think of a flat foot and then think of that what's going on at that talocardial joint. On the opposite side of the talocardial joint, we have page 402 for our lateral collateral ligaments. This one's a little bit easier. If you remember that the lateral collateral ligaments are on the lateral aspect of the ankle, then you know that the deltoid is on the medial aspect, right? So these are the ones that are most frequently injured because of their location because most of the time if we're going to roll our ankle, it's going to roll to the outside. So that's why they're most often the ones that are torn during a sprain, or they can just be lengthened out, maybe not torn, or a little part of it can be torn. Look at all the fibers that are within a ligament. So it doesn't have to be a complete tear, but it can be. Depends on the severity. We've probably all rolled our ankle at some point. So these lateral collateral ligaments commonly get damaged, stretched out, and because of what we talked about on that very first page, with the ligament being relatively avascular, it does have a blood flow, but the healing process is extremely slow. And then if you add in the type of shoes that we wear and how we hold our leg in our posture, our talocardial joint really has a lot of stress and just a lot of issues. So you can see in the pictures, there's some of the different views of how those lateral collateral ligaments are trying to protect the ankle, but it's difficult. Page 403, and there's lots of different views of what we're going to look at here, but I want you to notice at the bottom of the page, it reminds us of what retinaculum is, or retinacula. So in the pictures, notice these are all this extra bandaging, it's a way to think of that is helping to hold all the tendons, all the muscles in on that talocardial joint. There is some that are superior, there's some that are inferior, and then we haven't talked about the muscles yet, but we have extensor and we have flexors, which is in another picture. So we're going to have these extra retinaculum, just trying to hold stability and keep those muscles and tendons in place. On the next page, there's the flexor. On the top of page 404, so the flexor retinaculum. Next, we're going to go to the middle of page 404 and all of the information that is focusing on the center picture, which is the plantar surface of our foot. An aponeurosa is a broad, flat tendon, but in this case, it is very thick and superficial. It is our fascia, okay? So a thick superficial band of fascia. So if you touch the bottom of your foot, this is what you're going to be experiencing or what you're going to be feeling. So it is supporting the longitudinal arch of our foot. So again, think of that triangle. So all of this, and notice how it's going to each one of the digits. There's also a little extra that's more on that pinky toe side, on the lateral side. And here is where I have written tension. So I want you to think of the pathology of plantar fasciitis, which is where the plantar surface of your foot, the fascia, is inflamed or it has an irritation to it. Different levels of that inflammation can occur. And so over here I have written PORM, which is passive range of motion, which is something that you can do not only to teach to people, but you can do this to your clients that are potentially experiencing some of the effects of plantar fasciitis. You can do flexion and extension of the toes to affect this fascia, but passively. So just a little bend back, a little bend forward, without doing anything to their ankle, just to create a little less tension in that fascia. Way back in chapter 1, we looked at that superficial and deep fascia, and now we have a really thick superficial band that we need to try to reduce the tension, because remember, our fascia, 1 square inch can hold 2,000 pounds of pressure. That's a whole lot of fascia going on there, right? And depending on the size of the foot, how many square inches it is. So doing this passive range of movement, flexion and extension, can help to reduce some of the tension that people are experiencing in that plantar fasciitis. Page 405, just showing where we can feel the pulse in the foot. You might feel it if you're doing some manual therapy on the foot. We're showing the two sesamoid bones. Sometimes they're included in the 206 bones in our body. Sometimes they say there's 208. It's because of these two little guys right here. Maybe you can feel them on the bottom of your big toe, maybe not. But on the bottom of page 405, we have our bursa. We talked about the bursa that are located in the tibiofemoral joint. So now we have bursa that are trying to help with our tendon that's going down the back of our lower leg down to our heel and help to cushion the tendon against the bone or the calcaneus. Note here that we can have inflamed or thickened bursa because this is where our shoe hits. And during class time, we're going to find that on each other. We're going to look at our shoes and we're going to focus in on that because this can be an indication of several pathologies that people have or that they are suffering from, or symptoms or syndromes of different pathologies. So those are the other structures that are laying on top of the bones. The good thing about this chapter is there's not a ton of muscles, and there is also an easy way to think of the muscles that we're going to talk about in this chapter. So keep in mind that there always is an easier way to think of it. We're going to start with page 371. We're going to start at the top. And notice that I have written here, this is the posterior lower leg. So the muscles that we are going to talk about in this chapter are below the knee. But we have the posterior lower leg, we'll have an anterior lower leg, and then we'll have medial and lateral. So it's just going around the leg just like we did in chapter 6. So the two muscles are gastrocnemius and soleus. I know you can see them at the bottom, not as easy on this screen, but I know that you can see them there. The gastrocnemius has two heads, so it crosses also two joints. So on that bottom left-hand picture, you can see how each head is going to the femur, medial and laterals, to those condyles, those bumps on the back of our femur bone. Then we can see how the split of the two heads come down to split gastrocnemius. And right up here I have that gastrocnemius is rotund, but it's actually thinner than soleus. So I know when we think of like, the gastrocnemius has a lot of tension in it, we actually want to look at soleus for that. I want to just slide this up. Notice that both of these muscles both insert or blend into the calcaneal tendon, which formally is known as the Achilles tendon, but the proper term is here. So back up to the top to look at soleus. This one is deep to gastrocnemius. It has medial and lateral fibers that bulge out of the side of the leg, so we will be able to palpate this, and during class time we'll make sure that we can tell the difference. But it does go down a little further than the gastrocnemius. But this part where I have the arrows, super important. You absolutely need to know this for a couple different reasons. So first of all, the soleus is called the second heart because of the contractions that are helping to push that blood flow back up to our heart. But if you've ever heard people say that, if you're sitting for a long time, you should pump your ankles, it's soleus. But we have to do the proper action in order for that to actually occur. So just looking at the difference between what gastrocnemius looks like and then deep, we have this origin, this soleal line. Look at it's a diagonal. The very center will help you with this O and I part. So you can see at the top, back of the femur, where gastrocnemius originates. Soleus is down on the tibia, so it's lower. But then they both insert down here, down into our calcaneus bone via that calcaneal tendon. When we look at the other thing that they have in common, both of these are going to plantar flex our foot, which is pushing your foot on the gas pedal or the plantar surface towards the ground. Plant it in the ground. But gastrocnemius, remember, crosses two joints, the femur and the talocardial. So it also is going to bend our knee or flex our knee. The other thing that I have written here is that when we do plantar flexion for soleus, we are shortening the fibers. So we're shortening them up. And then on the bottom, I have written that dorsiflexion will lengthen it, gastrocnemius. So it's a difference in how these fibers are laying out between these muscles. So the medial and lateral fibers of gastrocnemius are kind of feathering to the side, but then they're straight up and down here. Same with soleus, straight up and down. So these fibers are very different, which is why they have common actions, but then also why different things will change them. I do want you to pay attention to what they have showing on page 373. This is what we'll do during class time, is being able to find the difference between soleus and gastrocnemius. So we'll define the bones, we'll palpate the difference between soleus and gastrocnemius. So those two were on the back of the leg. Now we're going to go to the two muscles that are going to be on the back of the knee. So this is the first one, page 374, for plantaris. The shortest muscle, but it has the longest tendon in the body. So when we look at the pictures on the bottom of 374, it's very small, about the size of your thumb, but then it has the longest tendon, which goes from that little short muscle all the way down to the calcaneus. So down to our heel. So a little better picture on the right side, seeing plantaris here. So this is our origin and insertion of this little bitty muscle here. It goes from the lateral femur all the way down to the calcaneus. It's a weak muscle, which means it's not a primary mover. So its job is to do plantar flexion at the ankle, which again is pressing on that gas pedal, and it's shortening the fibers when we do that. And it also is going to be weakly assisting in flexing the knee, but because it's so short, that's why it's not a primary mover. It can cause us issues, especially people who drive a lot. Then this can have some achiness going on into it. But then remember this big long tendon, and a tendon is connecting that muscle to the bone. It's got a long way to go. The other one that's on the posterior knee is on page 375. We have popliteus, which is located in the popliteal space or popliteal space. So let's just look at the views here of what this muscle looks like. And then look at the very bottom left-hand picture for the little origin, which is up on the femur, and then it inserts on the tibia. So this is the back of our knee. So back up to look at the paragraphs. We want to remember that it has a short belly, but it does have kind of a triangle, diagonal fibers to it. It is deep to the gastrocnemius and plantaris. So popliteus is the deepest muscle in the back of our knee, which is why it's in charge of unlocking the joint. That's the muscle that is unlocking our joint. So you've heard the term, don't lock your knees. It's this guy right here. Its job is to medially rotate our flexed knee. So if you're sitting, your knee is flexed, rotate it to the inside or medially, popliteus. And it's also to flex the knee, so it's going to make that knee action happen. The picture they have on the right-hand side here, we'll do this during class. It can be a tender area, obviously, the back of the knee. So we'll focus in on what that feels like so that we can be comfortable with our palpation skill should we need to access that muscle. Page 376 for two muscles that are on the lateral low leg or the outside. So fibularis longus and fibularis brevis are also known as peroneus longus and brevis. So if you remember that the fibia bone is on the lateral aspect of your leg, then you would know that fibularis longus and brevis are also on that bone. Fibularis longus is longer, fibularis brevis is shorter, which is what they mean, longus and brevis. Fibularis longus is superficial, or you could say fibularis brevis is deep, either way. And between the two of them, they are covering the fibula bone. So what I have underlined in the origin of fibularis longus, it's going up to the head of the fibula. Remember, it's longer, and then it's going down to the base of the first metatarsal and medial cuneiform. So do you remember which toe is your first metatarsal? Then we have fibularis brevis, which is lower on the lateral fibula. So this is how they cover that entire fibula bone. And this one is going to the tuberosity of the fifth metatarsal. Remember that knob that's on our pinky toe side? This is the big toe side. So it's the lateral two muscles of our lower leg, but one is going to the pinky toe side, the other is going to the big toe side, and one of the tarsals, the medial cuneiform, which is going to help us with our actions. So they're both assisting in plantar flexion of the ankle, so pressing on the gas pedal, right? Because we can feel our big toe and our little toe if we're doing that. But also they're going to evert the foot. So eversion and inversion are two actions that are going to potentially have a little bit of a complication in our thought process. But we'll focus on those when we get to the actions. The very bottom picture on 376 is helping us with that base of the first metatarsal, and here I have highlighted that tuberosity of the fifth metatarsal. So really from one side of the foot to the other, that will help us remember that these two muscles on the lateral low leg and what action they're creating. The extensors of the ankle and toe are next on page 378. And yes, I don't have a whole lot highlighted here because it's easier, I think, on this other page. So page 379, I want to start with just looking at this origin and insertion as an introduction to the names as well. Tibialis anterior, I bet means that it's on the anterior surface of our tibia. So super easy for that, right? So here we have tibialis anterior, origin, and then tibialis anterior, look at where it is on the surface of our foot, still on those bones. Then we have extensor hallucis longus. So this is going to extend our big toe, and it's long. So here we have the origin, extensor hallucis longus, and then it's going down to that big toe. And then the other extensor is extensor digitorum longus. I bet this one is going to extend my toes, and it's long. So it's a little longer than hallucis. It's further proximal, and then it's going down to each one of my toes, except for the big toe. So just 2 through 5. So collectively as a group, these are the extensors of the ankle and toes. So I think that's a little easier. The other thing that I want you to make sure that you have written down is the actions. So first they have an all-fire action. They're all going to dorsiflex the ankle, which is going to take the dorsal surface of your foot and lift it up, or you can think of taking your foot up off the ground. depending on what you're doing, it might involve the toes, it might not. Just depends on if you're engaging those other muscles. The other thing that I want you to notice is that extensor hallucis longus does inversion, tibialis anterior does inversion, but then extensor digitorum longus everts or does eversion of the foot. So keep that in mind because that has to do with where they're inserting and the action that they're doing. We'll talk about that more when we go through all of the action breakdown. I want you to make this little note that in tibialis anterior, dorsiflexion is an antagonistic movement to gastrocnemius. So that means the back of the tibia muscle is going to be antagonist against the muscle that's on the front of the tibia. The other thing that I want you to write down here under extensor digitorum longus is that when we do dorsiflexion of this muscle, we are shortening the fibers. So these things might only come into play later on when you're ready to focus in really more on a particular client or why they're experiencing what they're experiencing, or you're trying to help your knowledge of understanding what's happening at their ankle or their foot based on the conditions that they're telling you or their symptoms. The other thing that I want you to notice about these extensor muscles is on page 380. Keep in mind we have the retinacula as that extra bandaging, that extra strapping that is there to help hold these extensor muscles in place. So those are occurring on this complicated talocardial joint. Extra help. So then we have the opposite. We have the flexors. Page 381. We have the flexors, which are on the back of the lower leg. The extensors are on the front. The flexors are on the back. And to help us break that down, we have tibialis posterior, so that might help you remember. And then the other two have flexor in them. So if you can keep the groups together, you'll be able to remember that. I do have a couple things highlighted here, that these are deep to gastrocnemius and soleus. So if we can visualize where gastrocnemius and soleus are here. They are thinner, and you're going to have difficulty trying to tell the difference between these. On this bottom part of 381, notice that it looks like you can touch these, but also that this view is a posterior view. So gastrocnemius and soleus are on top of these. And then in the paragraph at the top, I have highlighted that these three muscles are going to curve around the medial malleolus, go deep, or the flexor retinaculum is going to be on top of them, but they are going to also have the tibial artery and tibial nerve that they are going to be touching up with. So when you look at these bottom pictures, we are going to be able to potentially have some nerve or artery impingement or compression from these three muscles. On the next page, we'll be able to see just a little more information on that origin and insertion. So just seeing where they are, again, this is a posterior view, so looking at the back, and they actually have the ankle in plantar flexion, so keep that in mind. But they're just trying to show you where the three muscles originate, where on the foot that they're inserting, so look at all the area, all right? So a lot is going to happen with their actions. So at the top of page 382, make sure that you write down they have these all fire actions together. They are going to do plantar flexion. So together all of these are going to put my foot to press on the gas pedal. And remember, they're on the posterior aspect of my lower leg. But they're also all going to do inversion or invert the foot. So again, we'll get to those because we're running out of muscles. So pretty soon we're going to be on those actions. There is some things that you don't have to focus in on, which is always a plus. So on page 384, 2 views of all these intricate muscles helping to hold those 26 bones together. I want you to be aware that, wow, we have a lot going on, but you don't have to learn all of these names, but we're going to talk about those here shortly. So just being aware, if you are going to be doing some manual therapy on someone's plantar surface of their foot, here's the next page, there's a lot going on. So dorsal surface of the foot, or that top part, so you can feel these tendons probably, maybe some of these muscles. This is where we looked at that triangle that's on our foot and how we stand and bear weight. So here is why you don't need to focus in on where each of these muscles are. So this is page 387. And these are having to do with the muscles of the foot. And again, I said I want you to be aware of these. But if you look at their names, it would tell you what they do. We have an extensor, we have a flexor, we have an abductor. They're going to the digits or the big toe, and they're either short or mini. So all of those actions are going to tell you by the name what they do. If you are going to go on and really focus on helping people with perhaps their ankle or foot, you can get into different therapies that are specific for people when they have injuries of the foot and the ankle. Then these are going to be what you're going to go back and study even more. You're probably going to take some continuing education about more things about the foot. The same goes on with these other muscles of the foot. So this is page 390. If you look at these names, extensor hallucis brevis, flexor hallucis brevis, adductor hallux, flexor digiti minimi brevis, this is our pinky toe. So all of the names tell you the actions that they would be doing to make our toes, of whichever toe it's attached to, work. The same with what's on page 391. So a little bit more complicated, but again, just be aware of how all these different views of our foot. The workbook will take you through several pages of exercises, so know that you don't have to focus in on them. And I feel confident that if you were to have any question from the state about what extensor hallucis muscle would do, you would know it would have something to do with the big toe, and you would probably be able to know that it's going to extend it. So that's why I feel confident if you take it apart, you'll be good. Now on to the actions. So page 369, and we're going to start at the talocardial joint or the ankle. We've talked about this with all the separate muscles, but what I want you to notice is plantar flexion, which is pressing on that gas pedal. Notice that we have some assisters and we have some weak ones. I want you to know the 3 that are making it happen, which is why they have the 3, and they're all on the back of the leg. Gastrocnemius, soleus, tibialis posterior, because if you push onto the floor with your toes or you press on that gas pedal, or it will raise your heel, or when you wear a high heel of any sort, these 3 muscles are going to be consistently engaged. But they're on the back of the leg, so it makes sense. The opposite action is dorsiflexion. So when you're lifting the top of your foot up, so I referred to that as like taking your foot up off the gas pedal, but you can also just lift the top of your foot up off the floor. It's probably going to be the ones that are on the front of the tibia that are going to make that happen, which is tibialis anterior, and extensor digitorum, and extensor hallucis longus, because we're lifting them up. We're extending them up. So the muscles on the back of the leg versus the muscle on the front of the lower leg. So very easy to think about it that way, rather than trying to memorize each individual one. Again, where the muscle is located is your key. The next page, so 370 at the top. So we talked about inversion and eversion when we were looking specifically at each muscle. And I said we would talk about it a little bit more. There is other views in the beginning of this book, so chapter 1, which will again show you some different actions of inversion and eversion. It is also terminology that you should have had in the anatomy portion if you've had that chapter. Maybe you haven't, so you'll hear these terms again for sure. So what I want you to notice is either we're lifting up the big toe arch or we're lifting up the pinky toe arch. I know those aren't the proper terms, but I'm trying to just make it make a little bit more sense. So if we look at inversion, there's 5. I had one student that said that she remembers inversion because you can see into the bottom of the foot. So if you look at the bottom or the sole of your foot, you can think, okay, that's inversion. So that big toe arch is lifting up. We have the muscle that are on the front and the back of the tibia, tibialis anterior, tibialis posterior. Then we have 2 flexor muscles. So we have the one that is going to the 2nd through the 5th digit and the one that is going to the big toe. And then we have 1 extensor. Extensor hallucis longus, because remember we're lifting up this hallux. So the flexor and extensor both have to engage to lift up that big toe. That might also help you remember what inversion is, because our big toe has to lift up. Eversion is the opposite. So there's 5 to look in, but only 3 to lift up that pinky toe side. So less, which that might help you keep the difference between which one is the big toe, which one is the pinky toe. Fibularis longus and brevis, which are on the lateral aspect of that fibula, which is also where your pinky toe is. And then extensor digitorum longus, because if you have to lift up this pinky toe, there's more than 1 toe that's going to lift. So if you do that on yourself, you're like, oh yeah, they all lift up together. So eversion, 3 on that pinky toe side, inversion, 5 to lift up that big toe side. So I'm hoping that this is making just a little bit more sense. The much easier aspect is what is on the bottom of 370. The muscles that are creating flexion of the 2nd through 5th toes, that would be the flexor digitorum longus and brevis. They tell you what they do in the name. And then extension of the 2nd through 5th toes is the same. Extensor digitorum longus, extensor digitorum brevis. So as a whole, not as many actions as some of the other chapters that you will have or have had, but just remembering where the muscles are located will help you greatly with their actions. And we're going to finish out just by looking at page 344. So this is a view that you see I've written there that I want you to know this. These are all of the areas that you want to be able to identify by this point of going through the entire bony structure, bony landmarks, and all of the muscles, tendons, etc.